So cardiac tamponade, this is something else that has nothing to do with an aneurysm. So this is just another issue that cardiac patients sometimes have. So cardiac tamponade, that is basically accumulation of fluid in the pericardium. Your pericardium is that small sac that has a little amount of fluid in it that helps the lubricate the heart when it beats. So they collect fluid in the pericardium right around here. So usually when someone starts to have this one, I'm sorry, when a patient begins to have cardiac tamponade or begins to get fluid in there, the patient will have narrowed pulse pressure, meaning that space between your systolic and diastolic becomes closer. That pressure causes the heart not to be able to function as well, especially ventricles. So you have narrowed pulse pressure. You have distended neck veins because fluid is probably backing up, and you also have what's called pulsus paradoxus. And you probably would have muffled heart sounds because you can't hear the heart sounds through that extra fluid. So, PVD, arterial disease, peripheral vascular disease. Different kinds of peripheral vascular disease. Are we talking arterial or are we talking venous? There's a disease called arteriosclerosis obliterans, hardening of the thickening of the walls. This arteriosclerosis obliterans usually happens at bifurcations, branching in the arteries. It's more common in the lower extremities, in the aorta, common iliac artery, or the common femoral artery. So this is a form of thickening. You've got plaque growing in there. You don't have blood that is can get through. So this is going to cause problems with your artery and your oxygenation and your blood flow. So peripheral arterial disease of the lower extremity. If you're non-diabetic, the most common is your femoral popliteal area. Patients can have femoral popliteal bypasses. If it's diabetic, it's usually below the arteries, below the knees, because you've got smaller arteries, so they are going to basically receive the brunt of your diabetes and your high sugars that are wreaking havoc on your arteries. Somebody that has peripheral artery disease, especially in the lower extremities, a common symptom is they have intermittent claudication. Intermittent claudication is when you're walking, you start having pain like in the calves of your legs. But if you stop walking, the pain goes away. That's because you're not getting enough oxygen because of your arterial disease. And now you don't have enough oxygen. It's like your heart, your muscles are screaming, they hurt, they don't have enough oxygen. If you stop walking, then the oxygen returns and it'll go away. So, intermittent claudication. Patients because of poor arterial flow are going to have neuropathies. So loss of feeling in the lower legs, numbness, these damage to your nerves. Lots of times, because of neuropathies, injuries go unnoticed. They don't know they have a blister on their foot or their leg. They don't know that other issues are going on. So if you can't feel the pain, which is a normal symptom for something going wrong, then injuries go unnoticed. You see these patients with arterial disease in the lower legs. They have their skin is very shiny. It's taut. They have a loss of hair on their extremities. The foot when elevated, pallor of the foot when it's elevated, because they don't have blood flow as well, so it becomes pale. Or when the leg goes down and now we got blood flow, all of a sudden it'll go extremely red because of the blood flow that's finally getting there. So these two things are classic symptoms for arterial peripheral disease. So testing, we can do Doppler testing to see the blood flow of the arteries. We can do an ABI, ankle brachial index. That is a good way to find out if you have arterial disease in your extremities. So when you have mild symptoms, you need to modify your risk factors. Risk factors are just the same as if you have coronary disease. What are your modifiable risk factors? Think of those. What are modifiable risk factors? We can put them on medications for peripheral artery disease. Aspirin obviously helps. Tyclid and Plavix will help the blood flow because it will decrease your risk of forming platelets. Claudication drugs. Here's two medications for patients that have claudications. Trental and Platal. Patients can be on ibuprofen. Maybe warfarin is warranted just for not forming any clots. Patients need to wear very comfortable shoes so they don't get any pressure sores, they don't get any blisters. They have to really watch heat and cold extremities. Heat and cold will decrease your blood flow to your extremities. So when your extremities get cold, make sure they're warm enough because we don't want them to have poor circulation. We can do angioplasties on patients that have poor arterial blood flow in the extremities. We can put stents in. We can do bypass surgery. We can put a graft in. We can do all the same kind of procedures we do for the heart for the extremity arteries. Same kind of treatment. Notice if you have an angioplasty, it restenosis after 1 year at 50% rate. That's pretty high. Coronary artery stenting, that lasts about 10 years, 12 years. So post-surgery, for anybody that has any of these procedures, the bypass, well, you want to monitor the bleeding, of course, hematomas underneath the skin bleeding. You don't want the patient to develop compartment syndrome. Compartment syndrome is where blood or it's cut off circulation and it cuts off all circulation, so it becomes compartmentalized. That's an emergency to take the patient to surgery. Post-surgery, these patients should not sit long periods of time. They shouldn't cross their legs. Sitting in the dependent position, that'll increase your edema as well. Crossing the legs does not help circulation. So these patients need to watch how much they're sitting, watch signs for infection. A lot of patients cross their legs all the time when they sit, or even when they're not sitting and they're lying down, crossing legs. Don't cross your legs. So if you don't fix arterial peripheral disease, then at some point the blood will stop flowing. You're going to have ulcers and gangrene. So you can have arterial ulcers. It's going to develop into gangrene. You'll be amputating toes and limbs. Now remember, if a patient is diabetic and they also have peripheral artery disease, you're just compounding the problem. Ulcers can develop over bony prominences. So the idea is, if we have to, we're going to save the limb as much as we can. It all depends on your comorbidities, what's the best treatment. But sometimes we have to do surgery to open it up, or because of the ulcers, if the patient waited way too long to get the treatment, then we may have to do amputation. But we'll do everything to save the limb. So put a stent in, put a graft in, do a bypass. Here's gangrene, pretty nasty, smells absolutely horrific.